Good evening. This is Garth Reynolds, your Executive Director for the Illinois Pharmacists Association, and welcome to this evening's program, Pharmacy Legislation Review 2021 Spring Session. I do not have any disclosures or conflicts of interest for this program. And let's discuss tonight's objectives for both pharmacists and technicians. And we'll be discussing pharmacy and healthcare related legislation effective in 2020, describe updates to federal and Illinois regulations related to pharmacy for 2021, discuss policy advancements and implications for pharmacy during COVID-19 pandemic, and review the Rutledge versus PCMA court case and the implications on pharmacy practice and patient care. Let's review our pretest questions. What was the bill numbers for the 2021 proposed PBM legislation? Is it A, Senate Bill 2008, B, House Bill 3036, C, House Bill 101, D, House Bill 3036, or E, both A and B? What types of cannabis became legal on January 1 of 2020? A, medical cannabis, B, recreational cannabis, C, medical and recreational cannabis, or D, none of the above? According to HHS and the PrEP Act amendments due to COVID-19, what is the minimum age that pharmacists may now administer vaccines? Is it A, 5 years, B, 3 years, C, 10 years, D, 2 years, or E, 8 years? What was the Supreme Court decision in Rutledge versus PCMA? A 0-8 decision for PCMA, B, a 9-0 decision for Rutledge, C, a 5-4 decision for PCMA, D, a 6-2 decision for PCMA, or E, an 8-0 decision for Rutledge? As with any program that we do for any of our affiliates, I do like to discuss and briefly review the Illinois Pharmacists Association and our mission. The mission for the association is dedicated to enhancing the professional competency of pharmacists, advancing the standards of pharmacy practice, improving pharmacists' effectiveness in rational drug use in society, and leading in the resolution of public policy issues affecting pharmacy. And it's that last portion that we'll be spending most of tonight discussing. IPHA is the voice for pharmacy in Illinois. We're the largest and oldest pharmacy association in the state, and we were founded on December 7th of 1880. Druggists of Illinois, elevate your profession and protect your business. These were the words of the first circular in October of 1880, and those words are still very valid 141 years later. And how we accomplish our goals is through professional development of our members and helping with the profession with educational programs such as this evening, government relations, which we'll also be discussing this evening, societal relations and how our members interact with both patient groups and their communities, research and information on how best we can collect and advance pharmacy practice, networking and forums with helping gather our members and interacting within the multiple facets of our profession, and helping set standards for both professional ethics and best practices, and organizational relationships and how best we can work together amongst our allied societies in healthcare. Political advocacy. The association actively monitors both state and federal legislation and how it impacts both your patient care and the profession of pharmacy. And we represent the membership on educating and discussing and advocating for these issues with key legislators and regulators. You can look at our new advocacy center and our legislative tracking report at ipha.org. Let's quickly look at how a bill becomes law. In Illinois, a bill can start in both either the House or the Senate, and it goes through multiple stages, mainly looked at as the 3 readings: first reading, second reading, and third reading. First, a bill is drafted by the Legislative Reference Bureau. We'll use an example of a House bill that would simply state that pharmacies shall be open on Sundays and close at 6 p.m. This bill would be assigned to the Rules Committee, and if it started in the Senate, it would be the Assignments Committee. It's the job of this committee to decide where a bill properly should be assigned for further in-depth investigation. After a bill has had first reading, which assigns its bill number, and it's had its committee assignment, then the committee process begins. And this is one of two places where an amendment can happen. And it's easier to have an amendment done in a committee because you have to advocate a smaller number of people than you would on the House floor. Let's say our bill passed out of committee. Now it's on what's called second reading. It's on the House floor. This is the other opportunity where a bill can be amended. It's called a floor amendment. There was no floor amendments in this case, and it went to third reading, or what you would consider to be normal floor debate. Let's say the bill passes. Now it goes to the Senate. Some may think that the bill would immediately go to the Senate floor for immediate vote, and that's not true. The Senate has just as equal the opportunity to scrutinize the bill just as the House did. So it goes to the Senate Assignments Committee through its first reading process, and then gets put into its substantive committee. In this case, it'd be Senate Licensing Committee. Let's say that there was a committee amendment now that said, let's change it from 6 p.m. to 7 p.m. And it passed the committee. Now it went to second reading, and there was no further floor amendments, and it was voted on and debated during third reading, traditional debate. And it passed the Senate. Now we have a bill that's passed both chambers, but there's been a change. It went from 6 p.m. closing on Sundays to 7 p.m. Now what happens is what's called concurrence. The original chamber, which in this case is the House, would vote on the change, and only the change, not the whole bill. So just the change from 6 p.m. to 7 p.m. Let's say the House concurs. Now it goes to the governor. The governor actually has 5 different options, which most people think he just has 2, which is to pass the bill or to veto the bill. In Illinois, a governor has 2 options to pass a bill and 3 options to veto a bill. When the options of passing, if the governor liked the bill, he could sign the bill, which would immediately make it go into law upon its effective date, or he can wait 60 days and do what's called put it in the drawer, and his name is automatically assigned to it, and the bill becomes law. If the governor decided he did not like the bill, he could total veto the bill and send the entire thing back to both chambers to review, or could do an item veto and say that he did not like that it was a closure on Sundays, but maybe it should be every day, or an amendatory veto where the governor changes the intent of the bill and says it should be for pharmacies and physician offices that they should close at 7 p.m. on Sundays. So if either of those happened, both chambers would then, in veto session, review the bill and would have to override the governor by a 2/3 majority in both chambers to be able to override any one of those 3 vetoes. That's a quick review of just how a bill becomes law in Illinois, but always remember there are rules in both chambers as exceptions to keep bills moving and also to make sure to address emergent legislative needs. So let's talk about the 102nd General Assembly. The Senate is made up of 41 Democrats and 18 Republicans, and the House is made up of 73 Democrats and 45 Republicans. Democrats have a supermajority in both chambers, which means that the Republicans do not have the numbers to be able to sway the majority of a vote and the outcome of a vote if they voted alone. Bills filed so far in the Senate is well over 2,800 bills, and in the House, it's well over 4,000 bills, and that's been since January 1st. That's over almost 7,000 bills in the first 3 months of this year, and that is a significant number of bills for any legislature to review and take action on. Usually we're monitoring about 300 bills. This year, it's closer to about 500 bills. There's a significant number of healthcare and COVID-19 related bills. And the General Assembly session is a 2-year session from January 1st to December 31st of 2022. So let's take a look at the Let's take a look at the General Assembly committees. Now, this is not an exhaustive list. This basically gives you a list of the most common committees that we interact with. And we already talked about healthcare licenses, but you should also see on the House side here on the left, not only do we have insurance and revenue, but we also have prescription drug affordability. This is a committee that started in the 101st General Assembly 2 years ago, and entertains bills on not only just prescription drug costs, but also PBM reform legislation. In the Senate, we have appropriations, human services, and insurance. License and activities has actually now been separated, and license activities and pensions are now two separate committees. In addition to the General Assembly, we also advocate and lobby with the various executive departments which enact the administrative rules for the various acts. And the most common is the Department of Financial and Professional Regulation, or DFPR, which is also the Board of Pharmacy. Department of Healthcare and Family Services, HFS, or Medicaid. Department of Human Services, DHS, which houses the Prescription Monitoring Program. The Department of Insurance, which is supposed to be enforcing and oversight over pharmacy benefit managers and health insurance. The Department of Public Health, which we've definitely been involved with over the last year, not only for COVID-19, but we've had long-term relationships in working with the department on chronic disease state management and pharmacists' role within that. And then Illinois CMS, or Central Management Services. And it is Illinois CMS and not the Centers for Medicaid and Medicare Services that we traditionally think about. But this Illinois CMS is actually the state's HR department, and is responsible for the insurance of the state employees and retirees. So any of the state insurance plan issues of the employees, this is the department that we interact with to help resolve those issues. And this is just a listing of the various acts that we're responsible for as a pharmacist and that we monitor for legislation. This is not a complete list, but it gives you an idea of the numerous ways that legislators can impact our profession. So let's do a quick review of 2019 bills that passed that went into effect in 2020, which I know we may have gotten a little bit lost because of our focus on the COVID-19 pandemic. First was House Bill 465, which was phase one of our PBM reform bill. We're so glad this passed, and this was a monumental effort. And I really want to thank everyone that helped make a phone call, make an email, that showed up in Springfield to help advocate for this bill, because this really was an all hands on deck effort and would not have been such a success if it wasn't for all of our members, all of our stakeholder organizations, and all of our local affiliates helping get this bill passed. So thank you. This bill amended the insurance code and created a whole new section devoted just to pharmacy benefit managers. It also amended the Public Aid Code, the Pharmacy Practice Act, and the Managed Care Reform and Patient Rights Act. It helped establish for the first time definitions for PBMs, maximum allowable costs and their lists, retail pricing, and pharmacy service administrative organizations. It stated that MAC pricing had to be updated by the PBM at least every 7 days. Also established a 14-day appeals process, and that the PBM had to respond within 15 days of that claim. If denied, the PBM would have to provide rationale and the indice used. If the appeal is sustained, adjustment is effective from the date of the claim, and the adjustment should be also applied to all similar network pharmacies. Plan sponsors also have new additional rights to audit the PBM for full disclosures of rebates from their manufacturers that they make in those agreements, actual amounts paid to the pharmacies, and any considerations for brand dispensing, including biologics. The bill also looked at patient protections on gag clause prohibitions. Now pharmacists don't have to be concerned about being in violation of a contract if they can tell a patient about a known cost-saving alternative. Requires the PBMs to be licensed under the Department of Insurance, and that the department may review their corporate structure. Protects patients additionally from being billed inappropriately for seeking medical treatment during an emergency situation and being inadvertently mischarged. As an example, patients seeking symptoms for a heart attack, but really they had an aggravated episode of heartburn. Patients are protected against copay accumulators, specifically for specialty medications. Medicaid now has the authority over the contracts for both between the PBMs and the pharmacies, where they only had the ability for the contracts between the MCOs and the department. Also gives Medicaid the ability to approve changes to the contracts and prohibits DIR fees on the pharmacies without approval of the department. Medicaid must submit a report every year to the General Assembly with updates of any contract or contract issues, formulary and dispensing fees, or any other MAC concerns that's been brought forward. PBMs must inform Medicaid of any conflicts of interest, and they shall disclose to HFS any exclusivity contracts with manufacturers, the percent of claims paid to the pharmacies, the aggregate amount of fees imposed on pharmacies. Also must talk about the average annualized percentage of revenue not paid to the pharmacies, also known as spread pricing. Pharmacies no longer are prohibited from dispensing amounts of medications different from amounts dispensed by pharmacies owned or co-owned by a PBM, also known as a PBM affiliate. So this went effective on January 1 of 2020, but didn't really start impacting contracts until July 1st of this past year. This is really only the beginning of how we need to continue to express our movement towards PBM reform, helping preserve patient care and patient access, and preserving pharmacy practice. And we'll talk more about this later on. Senate Bill 1715, brought forward by Senator Hastings, amended the Pharmacy Practice Act and added in a couple new statements in the practice of pharmacy definition. This would allow pharmacists to administer an injectable long-term antipsychotic with a valid prescription or standing order upon completion of a CE course. Also, for the administration of long-acting and extended-release forms of opioid antagonists. Also, after initial administration by a physician, and then with a valid prescription or standing order, and also completing of a training course. And this went effective on January 1 of 2020, and IPHA has developed a training program that meets the requirements. House Bill 822, brought forward by Representative Halpin, amended the Cares for Students with Diabetes Act and stated that students may possess a supply of glucagon and that the prescription could be in the name of the school, similar to how we handled naloxone, that it can be in the name of the business, like a school or a law enforcement agency if they want to obtain naloxone, or the name of a school for EpiPens. So a school nurse or delegated care aide may administer in accordance with the student's diabetes care plan, or if the student's glucagon is not on site or has been expired. And this went into effect in late August of 2019. Senate Bill 667, brought forward by Senator Menard, amended the insurance code and capped patient out-of-pocket expenses for insulin at $100 per month. The Department of Insurance also had to produce a report on insulin pricing, which they conducted in 2020. Cost caps would only apply to insurance plans that are oversaw by the state of Illinois and the Department of Insurance, which will also include the state employees. So whenever we put in an insurance legislation through the Department of Insurance, it doesn't impact Medicaid patients, it doesn't impact Medicare patients, and anyone who has an ERISA plan are not covered under those type of legislation since they're regulated on a federal level. The cost savings provisions actually went into effect on January of this year in 2021, even though the bill went effective on January 24th of 2020. House Bill 2160, brought forward by Representative Conroy, looked to address prior authorization forms and trying to find a uniformity in an electronic prior authorization process, and amended both the insurance code and the public aid code. It created a task force, which included 2 pharmacists with IPHA did have representation on, and we deliberated over the summer in 2020 to help with making guidance for both in the Department of Insurance and HFS in providing for a uniform electronic authorization process. And also, PBMs must respond within 72 hours of a prior authorization request and 24 hours for an urgent need request. This went effective on January 1st and started impacting contracts starting on July 1st. House Bill 2259, with MCO preferred drug lists, brought forward by Representative Feigenholz, amended the Public Aid Code and stated that no later than January 1st of 2020, that HFS would develop a standardized format for a standardized formulary and would also develop a task force to help address these issues. It also included a pharmacist, which IPHA was able to provide a representative. This task force did have a delay in meeting, and they finally were formed and had their first meetings in the first quarter of this year in 2021, even though this bill went effective July 1st of 2019. Excuse me. Senate Bill 1665, brought forward by Senator Hastings, amended the Controlled Substance Act, and it removed veterinarians from registration and reporting responsibilities to the prescription monitoring program. After many years of discussion with the veterinarians amongst the other healthcare providers, it was decided that we were asking a lot on the veterinarians to have access to the prescription monitoring program, and it really became an ethics and a HIPAA issue about whether a non-human healthcare provider should have access to human prescription data. And it was decided that we could not resolve the ethics and HIPAA issues, and we decided, at least at this point, that we would remove the veterinarians from the responsibilities of reporting and checking the PMP, but that there needs to be increased education on reporting to law enforcement when they would have individual issues that they would confront. That went effective on August 16th of 2019. House Bill 3435, epinephrine injector insurance, brought forward by Representative Carroll. This amended the insurance code and stated that for group and individual policies that they shall cover medically necessary epinephrine injectors for anyone 18 years and under. One of our concerns was that it did not address the exact copayment or cost to a patient. As we saw in previous legislation, such as the Heroin Crisis Act, the insurance companies still applied high copays to some of these medications and still claim that they're compliant because technically they're covered. So we continue to work on trailer bills of this legislation now in the 2021 session of trying to address for an affordable copay philosophy. House Bill 1438, the Cannabis Regulation and Tax Act, brought forward by Representative Cassidy, created the Cannabis Regulation and Tax Act. It stated that anyone 21 years or older could possess, use, and purchase small amounts of cannabis for personal use. It did allow for some limited cultivation for personal use under certain situations. It was one of the first major legislations in the country to address expungement of minor cannabis violations and released a number of individuals from incarceration because of these violations, promoted cannabis business ownerships in individuals and communities of high poverty that had been impacted by the war on drugs. And it makes the previous medical cannabis pilot program a permanent program in the state. The effectiveness of some provisions went in as early as the summer of 2019, with most of the bill being enacted on January 1st of 2020. There were some initial bills, also like Senate Bill 2023, that also passed that helped address some financial issues as well. House Bill 2896, brought forward by Representative Flowers, for creating a diversity healthcare task force. This would amend the Department of Public Health and allow for a creation of a diversity in healthcare professions task force, which would include 2 pharmacists. We have been asked to provide names, which we have, but as far as our knowledge, this task force has not been activated as of yet. And this would examine education, mentorship, and employment opportunities for all communities in Illinois, and making sure that everyone has equal opportunity and equitable opportunity to become a healthcare provider. And this went effective on January 1 of 2020. Let's quickly talk about the Collaborative Pharmaceutical Task Force that has been in place for the last 2.5 years. So why do we have the task force? Well, if you remember the Chicago Tribune articles a number of years ago that really was looking at patients, the pharmacies not catching drug-drug interactions and not necessarily educating patients on their prescriptions. And so this led to the creation of a task force, which was made up of voting members of both IPHA, ICHP, the Illinois Retail Merchants Association, the Illinois Association of Long-Term Care Pharmacy Providers, the Illinois Hospital Association, the Med Society, and the Teamsters. Non-voting members were from University of Illinois Chicago, UI Health, and the Department of Financial and Professional Regulation. We were chaired by Phil Burgess, who is a former member of the Board of Pharmacy and former chair, and at the time was a member of the NABP Executive Committee. Later, the task force was expanded to include additional members from IRMA and the Teamsters and 4 legislators. We met monthly from January of 2018 until August of 19, and then again, and we were extended until October of 2020. We addressed 16 issues stated in House Bill 3462, which we'll go through here in a moment, and discussed any other issues related to the advancement of pharmacy practice and patient care that were brought forward to the task force attention. Such issues were whistleblower protections, pharmacy technicians on duty, prescription limits, pharmacy technician hours, prohibiting of distractions, mandatory breaks and lunches, no work during a break, triple pay for no work, or triple pay for no break, the establishment of break rooms, the establishment of break records, an 8-hour day limit, maintaining error records, reporting of prescription discontinuation, patient verifications for e-refills or auto refills, and detailed automated prescription refill notices, pharmacy technician continuing education employee terminations, and reviewing systems for compensating pharmacists in Illinois. Excuse me. We first looked at the whistleblower protections, and we stated that whistleblower protections, according to the task force review and advice and testimony that was provided to the task force, was covered under current law. For pharmacy technicians on duty, the task force recommended against any adoption of any additional language that was not covered under the current Practice Act or rules. There was a proposal for prescription limits and technician hours, and instead of establishing a quota or a prescription limit, the task force recommended for adoption of what was called grounds for discipline to include language that would address failure to provide a work environment for all pharmacy personnel that protects the health, safety, and welfare of a patient. So prohibiting distractions. It also included this grounds for discipline language, but continued to state that a pharmacy must have sufficient personnel to prevent fatigue, distraction, or other conditions that interfere with a pharmacist's ability to practice with competency and safety or creates an environment that jeopardizes patient care. Also, on breaks and lunches, the task force recommended for adoption that a pharmacist working longer than 6 continuous hours would be allowed a break of a 30-minute uninterrupted meal break and a 15-minute break. If they worked for an additional up to 12 hours, they would also receive an additional 15-minute break. So 2 15-minute breaks and a lunch. So no work during break. Again, we established that language for grounds for discipline, and that would then fall under also that failure to provide a working environment for all pharmacy personnel that protected the health, safety, and welfare of a patient. We recommended against any adoption of any language for a triple pay for no break. We also recommended against any adoption of a language for requiring break rooms. And we did establish that employers would have to keep and maintain a record of breaks. And we recommended that on an 8-hour workday, we recommended adoption of language that would state that a pharmacist, a student pharmacist, or technician would work no longer than 12 continuous hours per day. And then maintaining error records, we suggested that approval of a continuous quality improvement or CQI program be established at all practice sites. The report also included recommendations that starting January 1st of 2021, that pharmacies would use the script standard for all electronic prescriptions. That would allow for pharmacists to be able to EDC a script, and if they did, they could then would have to report that within 2 business days to a physician. Patient verification. The task force recommended that prior to a prescription that has a refill on file for a prescribing practitioner for an auto refill, that we would need the permission of the patient to enroll them into a program. So no longer any auto enrollment and auto refill. We also looked at pharmacy technician continuing education standards, and we realized that there is some movements in the industry to enhance the education of technicians. And so we did make some recommendations for looking at training. We also recommended, as with some task forces, the establishment of an additional task force to take a look at and study the compensation methods and the barriers to pharmacists being appropriately reimbursed for medication product and remunerated for professional services. This resulted in Public Act 101-0621. And this came about from Senate Bill 2104, brought forward by Senator Jones and Representative Zaleski. This renewed the Pharmacy Practice Act, which originally was going to sunset at the end of 2019, and extended it to 2023. It set forth that the task force was going to be continued until October of 2020, which we did, and that it added those additional members that we spoke about earlier. But it changed. So it took a look at what the recommendations were of the task force, and this is what became law. So we clarified the definition of a technician and stated that a technician may be delegated to perform any task within the practice of pharmacy if specifically trained for that task, except they cannot do patient counseling, drug regimen review, or clinical conflict resolution. This opened the door for pharmacy technicians in Illinois to be able to immunize patients. And that's where we were one of the first states after Idaho to be able to allow technicians to immunize prior to the emergency proclamations during the COVID-19 pandemic. This also established that starting in 2022, that certified technicians would have to complete an ASHP, ACPE program or equivalent training before they could apply to be a certified pharmacy technician. It also stated that student pharmacists, and technicians are to be scheduled no more than a 12-hour shift. Working 6 hours, that a pharmacist would be provided a 30-minute lunch and a 15-minute break. And if a pharmacist is scheduled for 12 hours, they're to be an additional 15-minute break. If the pharmacy or the business has a private break room available, that pharmacist is entitled to the breaks, must be given access to that private break room and allowed to spend their break entirely in that room. Now these all went effective January 1st of 2020. These are some of the exceptions of and also what happens whenever a pharmacist is on break. So a pharmacy may, but is not required to close when the pharmacist is allowed to take a break. So the pharmacy can continue operating, but there's some exceptions here. So if they don't close, the pharmacist shall remain within the licensed pharmacy building or within the establishment to which the pharmacy is located in order to address any emergencies. A technician or student is authorized by the pharmacist and may continue to be on duty and authorized to continue to perform other duties under the Act, but no duties reserved to pharmacists and student pharmacists alone under the Act that require professional judgment of a pharmacist may be performed by technicians or other personnel. So, if a patient comes to pick up a prescription, they have to be told that the pharmacist is on break and that they have the option to wait. If they don't want to wait, then they have to obtain information of how the pharmacist may contact them. And the pharmacist must make a reasonable effort to contact them and document those at least two attempts to contact and counsel the patient. If a pharmacy is staffed by 2 or more pharmacists, we don't have to worry about those exceptions that we just talked about. We ask that the law mandates and that you stagger the breaks so that at least 1 pharmacist is on duty, that you must keep records, and that if there is an issue of an emergency, a pharmacist is able to work through a break or a lunch. But again, this has to be an emergency situation and is the decision of the pharmacist in their professional judgment, not a decision of a manager, decision of a pharmacist. For patient auto-enrollment programs, a patient must enroll each medication to an auto-refill program that went effective January 1 of 2020. And then that electronic discontinuation protocol went effective on January 1st of 2021, and that you need to be making sure if you have an e-discontinuation order that you're notifying the physician that you received and acted on that order. The use of advertisements and making solicitations, this was added to the violations section. So if someone could be fined in violation of the Pharmacy Practice Act if the use of advertisements and solicitations may jeopardize the health, safety, and welfare of patients, including but not limited to the use of advertisements or solicitations that are false, fraudulent, deceptive, or misleading, or include any claim regarding a professional service or product or the cost or price thereof that cannot be substantiated by the licensee. And that went effective on January 1 of 2020. Also in the violations, requiring a pharmacist to participate in the use or distribution of these advertisements and making solicitations that may jeopardize the health, safety, and welfare of a patient could be considered a violation. Also, it can be considered a violation for failing to provide a work environment for all pharmacy personnel that protects the health, safety, and welfare of a patient. And it includes some detailed information there. So one of the things we put into the act, and it was more of a reminder, is that any person who reports a violation of the section to the department is protected under subsection B of the Illinois Whistleblower Act. This didn't add any additional powers or protections in the Pharmacy Practice Act. It's more just saying you are protected under this, even though you're already protected under that act without it being named. Let's quickly review on how to file a complaint with the department. You would go to idfpr.com, and they have a electronic or a paper form that you can fill out. I recommend filling out the online form because it goes directly to an inspector who then can follow up and take action on it a lot quicker than if it was mailed in. You would go to the website, and you see there where it says file a complaint there in the center. You would file here in the third column, professional regulation, and then you have the option to file an online complaint or a printed form. And here's the form itself. So now let's shift our direction to the federal level and talk about Rutledge versus PCMA Supreme Court case and why it's so important to pharmacy practice and patient care going forward. The Supreme Court reviewed a case from the U.S. Court of Appeals in the 8th District that ruled that certain PBM regulations enacted by the state of Arkansas, and specifically Act 900, were preempted by the federal law ERISA, meaning that the state did not have the authority to regulate employer or union-sponsored health plans. The 8th Circuit determined that Arkansas's laws were impermissible related to and connected with employee health plans under ERISA. It also said, pursuant to that the United States Solicitor General did file an amicus brief on behalf of the United States, arguing that the 8th Circuit ruling was incorrect and contrary to established Supreme Court precedents from other courts of appeals. And just so that you know what the 8th District is, that is basically the upper Midwest and Missouri and Arkansas. We're in the 7th District, which is just Illinois, Indiana, and Wisconsin. And that's important to know because some of this PBM march to the Supreme Court started with early legislation in the first Circuit Court of Appeals, which it was a case in Maine. And then 2014 really started the battle in the 8th District with the PCMA versus Gerhardt, which was a case based on the Iowa PBM reform legislation. And then came Act 900 a couple years later, and the Iowa case was dismissed on the circuit level, but it was upheld at the appellate level. Then came PCMA versus Rutledge, also in 2015, which is the focus of the argument. The state of Arkansas won the circuit court, but then PCMA won the appeal. And that's what started the movement of really trying to get the attention of the Supreme Court, saying we needed to have them to take a look at this case. So with that, in 2019, attorney generals throughout the United States submitted requests for the Solicitor General of the United States. And the Solicitor General of the United States is the second or third highest ranking attorney with the Justice Department. And their job is they're basically they fill the similar role of a state's attorney, but their job is to argue cases on behalf of the United States government to the Supreme Court. And so in 2019, in late 2019, the Solicitor General filed a brief that stated to the Supreme Court that, in his opinion, that the Court of Appeals erred in holding that ERISA plans were preempted by ERISA, and that the federal government argued that Arkansas's PBM regulation, again, did not have an impermissible connection with ERISA plans, and that the state had a right to intervene. So the Supreme Court would review the Eighth Circuit's ruling and potentially provide clarity on the extent at which the states would regulate PBMs and serve ERISA plans. And the federal government had taken the position that the federal law does not preempt the states and that the states have rights in regulating PBMs. So now we're going to listen to some of the segments of the arguments in the 20-minute debate of presentation of the case to the Supreme Court.
The Honorable, the Chief Justice and the Associate Justices of the Supreme Court of the United States. Oyez, oyez, oyez. All persons having business before the Honorable, the Supreme Court of the United States, are admonished to give their attention, for the Court is now sitting. God save the United States and this Honorable Court.
We'll hear argument first this morning in Case 18-540, Rutledge versus Pharmaceutical Care Management Association.
Thank you, Mr. Chief Justice, and may it please the Court. Pharmacy benefit managers are drug middlemen that reimburse pharmacists for the cost of prescription drugs. Those reimbursements are frequently below a pharmacist's cost. That drives pharmacists out of business, and it has left many communities without a pharmacist. Ag 900 responded to that practice by regulating what PBMs pay pharmacists. That response isn't preempted for three reasons. It doesn't regulate benefits, it doesn't regulate plan administration, and it doesn't regulate or discriminate against ERISA entities.
Is your approach focusing on who is being regulated or what is being regulated?
It is focused on what is being regulated. As I said at the outset, our test is, does the state law directly regulate a central manner of plan administration? Now, you're right, Mr. Chief Justice, that we devoted a portion of our brief to refuting what we understood to be respondents' only way of distinguishing travelers, which was to say that the law in travelers fell on insurers and not plans themselves, whereas the law here does. And our response to that argument was twofold. First, to say that that's just a misreading of the state law here. It doesn't apply directly to plans. But more importantly, secondly, that even if it did, it wouldn't matter, because at the end of the day, pharmacy reimbursement just isn't a central matter of plan administration.
And the second, as my friend mentioned, is that if the state law produced economic effects as to force the ERISA plan to adopt a certain scheme of coverage, it would indeed be preempted.
Well, here, it's not the state or the pharmacy's fault that the PBMs have such Byzantine procedures that affect drug prices.
Okay. Along similar but different lines, what do we do with the fact that there are plenty of ERISA plans that operate without pharmacy benefit managers? There are plenty of pharmacy benefit managers that provide services to non-ERISA plans. And, of course, your clients here are, as I understand it, all pharmacy benefit managers and no ERISA plans. We don't have an ERISA plan that's actually complaining about this before us, as I understand it.
Yes, that's right. I mean, there are amicus briefs filed by sponsors of ERISA plans, but the plaintiff in this case, and therefore the respondent here, is the the Pharmacy Benefit Manager Association.
Really, our point is that Act 900 doesn't regulate central plan administration. And to pick up on Mr. Waxman's last answer, when the court talks about central plan administration and binding plans to things, really what it's talking about is binding plans to decisions about who's a beneficiary, what's the benefit, what's the degree of coverage, that's the copay, coinsurance rate, et cetera, and how those things are determined. It's not rates. It's not what a third-party administrator pays for a service provider. And the fact that that's what we're talking about here really makes this case exactly like Travelers and makes this an easier case because Travelers has already addressed that issue. Lastly, to end on a question that Justice Gorsuch asked, which is about the limiting principle, I think that's really the problem with PCMA's argument. There's no limiting principle. If you accept their position that cost, anytime a regulation imposes cost, that can lead to preemption because it might affect the benefits calculation, that really has no limiting principle. It would frankly preempt things like state minimum wage laws that have exactly that same effect. So we would ask that this court reverse the judgment below.
Thank you, counsel. The case is submitted.
So this is a picture of IPHA President Cody Sandusky in front of the Supreme Court on the day of the hearing of Rutledge versus PCMA. IPHA was fortunate and proud to honor Illinois pharmacists and our patients on this very important day, and probably the very first time pharmacy as a profession was represented in such a substantial way in a case in the Supreme Court. And we were very fortunate and honored to be there with our fellow pharmacists from the Arkansas Pharmacists Association and also the National Alliance of State Pharmacy Associations, the National Community Pharmacy Association, and the American Pharmacists Association.
The honor.
So, like we said, the Solicitor General filed his brief back in December of 2019. The Supreme Court officially took up the case in late January of 2020, and the ball officially started rolling. And that led to mid-February in 2020, just as everything else, as we'll talk about in a moment, was about ready to come to a screeching halt. We had a major filing of a brief by the state of Arkansas Attorney General, Leslie Rutledge, who is the Rutledge of Rutledge versus PCMA. The state of Arkansas filed their initial brief, which has set the stage for their arguments to the court. And then what also was able to be filed that day was what's called amicus briefs, or friend of the court briefs. And the Arkansas Pharmacists Association, along with APHA, NCPA, NASPA, and 49 state and the District of Columbia Pharmacy Associations, including IPHA, filed a brief on behalf of the profession saying enough is enough. NACDS also filed a brief. So did the Food Marketing Institute, which also had the signatory of the Illinois Food Retailers Association, the National Association of Specialty Pharmacy. And this is also was very encouraging at the time in February. The state of California and 44 other state attorney generals and the Attorney General for DC, including our very own Attorney General Kwame Rule, also filed a brief saying that the court needed to take a look at the position and support the position of the state of Arkansas. The American Medical Association also filed a brief on behalf of pharmacy. So did the National Council of Insurance Legislators, AARP, the AIDS Foundation, and the Alliance for Transparent and Affordable Prescriptions, which is an alliance of physicians for more transparency from PBMs. So PCMA is the Pharmaceutical Management Association, which is the lobbying organization for the PBMs. They were able to file their brief on March 25th. Any individuals that wanted to help support them had to do it on April Fool's Day on April 1st. The state of Arkansas was allowed to provide a rebuttal brief on April 17th. And originally, oral arguments were supposed to be heard on April 27th, but as we know, the world came to a halt. But eventually, the Supreme Court started to move to teleconference hearings, which is eventually what happened in our case. And it originally was supposed to be rescheduled for June, but that got delayed as well. Well, then came a reschedule to have the hearing on oral arguments on October 6th, and it was going to be virtual, which is what happened. And of course, as we all know, just 2 weeks prior to that, we lost Justice Ruth Bader Ginsburg. And it was already postulated that she would have been a yes vote for pharmacy. And so this kind of made everyone a little uneasy as we were going into this, but not discouraged. We still had a lot of support from looking at what the legal arguments were for the justices. Because again, unlike a senator or a representative, you can't just lobby the justices. You have to kind of look at the writings that they have to be able to kind of hypothesize where they're going to decide. And what was a little interesting to find out is, we had the oral arguments on October 6th, but because that was the beginning of the new Supreme Court session, they actually had until June 30th of 2021 to be able to release a written decision. So we didn't know when they were going to decide this. And so we were given a very early Christmas present on December 10th with the Supreme Court decision. And not just a decision in pharmacy's favor, ruling for Leslie Rutledge in the state of Arkansas. It was an 8-0 decision, which blew everyone away. We all thought we were going to come with a 5-3, a 6-2, 7-1. We did not think that pharmacy was going to win and that patients were going to win with an 8-0 decision. This helps set up a stage that pharmacy and the states have rights and that patients have rights to their pharmacy and that pharmacy benefit managers have the right to be regulated by states. And that brings us to the 2021 spring session. IPHA has submitted, working with Senator Dave Kaler of Peoria and Representative Greg Harris of Chicago. Senator Kaler is an assistant majority leader in the House, and Greg Harris is the majority leader of this. Dave Kaler is the assistant majority leader of the Senate, and Greg Harris is the majority leader of the House. So we are lucky to have two leaders in their parties and in the chambers as the sponsors of our Phase 2 PBM reform bill. And we're glad to have Greg Harris back on board as our sponsor because he was a sponsor of House Bill 465. Senator Andy Manar, as some of you may or may not know, stepped down from the Senate just this past January to take on a role as senior advisor to Governor Pritzker. So where do we go from here? So the foundation of our bill for this year came from House Bill 465, our established bill. We started to incorporate language that was worked on as a model right after the decision that was developed by NASPA and NCPA to respond to the unanimous court decision in favor in Rutledge versus PCMA. So we looked at a lot of what that model language was looking at was already in some of the bits and pieces and the blocks to build upon were already in our 465. So we just had to kind of build upon that. And so it adds additional language for MAC pricing, adds language concerning pharmacy benefit manager affiliates, adds protections for pharmacists. So if they have an underwater claim that they could actually decline, but we added additional language that states that in the interest of patient care, that the pharmacist should still provide the medication to the patient, but yet report for a quick action by the Department of Insurance investigating with the PBM to find out what happened with that claim. Because it was interesting to note that in the Supreme Court decision, Justice Sotomayor, who wrote the decision and had a concurrence from Justice Clarence Thomas, that Sotomayor said that it is not the fault of a pharmacy if they wish to decline a prescription. The fault is with the PBM for offering a below cost reimbursement. So it is the fault of the PBM when it comes to the establishment of the pricings and the reimbursements. This bill also adds language for pharmacy professional dispensing fees, not just dispensing fees, but professional dispensing fees, prohibits PBM assessment of any fees, would prohibit retroactive fees such as DIR fees, prohibit pharmacy PBMs from charging copays greater than the cost of the medication, enhances our any willing provider language that we've had on the books for well over 30 years, and prohibits discrimination of patient choice that want to utilize a pharmacy to participate in the network. We also incorporated some language from the National Association of Insurance Commissioners, looking at accessibility and fiduciary responsibility, looking at language for other PBM prohibited practices, starting to look at network advocacy, language on patient choice and prohibiting patient steering, and protecting patient data. We also looked at our old pharmacy audit bill from 2018 and brought it back onto the table that we need. There's 42 states, that have audit protections in the state, and Illinois deserves to be one. We added additional payment parity for fee-for-service and managed Medicaid, stating that if whatever pharmacists are paid under fee-for-service is that's what also should be paid for managed Medicaid. And we need to enhance that and take a look at the National Average Drug Acquisition, or NADAC, plus a professional dispensing fee. Also look at payment parity as a floor for NADAC plus professional dispensing fee for commercial plans as well. One of the things that we have to look at, and if COVID has taught us anything, the underpayment of healthcare has got us to the situation we're in where we are underprepared and understaffed to take on the emergency that we've been dealing with for over the last 13 months. And that we have to treat healthcare and pay for healthcare at the level of care and service and the medications that are needed. Yes, they're expensive, but it is a professional service, and we must recognize that. House Bill 135, brought forward by Representative Musman, is our effort to continue to work on hormonal contraception by adding prescribing and dispensing a hormonal contraception definition to the practice of pharmacy. This would be done through a statewide standing order. It would require that pharmacists who wish to do this would have to complete a training course. They require patients to complete a self-screening risk assessment tool prior to dispensing, and establishes coverage for pharmacy care as a consult, both under payment for that under commercial and Medicaid. So this has been assigned to healthcare licenses, and actually all of our bills have been assigned to committee and actually will be heard this week actually. And House Bill 135 and Senate Bill 2008 are actually scheduled to be heard this Wednesday, or actually earlier today. Let's briefly talk about COVID-19 policy and the many things that have happened over the last year. IDFPR, Medicaid, the Department of Insurance established a number of policies to help, and proclamations and guidances to help address the ever unfolding needs that we had at the early days of the pandemic. IDFPR extended CE and license requirements up until September of last year from March of last year. There was an encouragement of expansion of compounding of hand sanitizer across the board. The expansion of telehealth services was allowed also for out-of-state providers. Expanded delivery of medications without any restrictions. Allowed pharmacies to remote process prescriptions. Prescriber and pharmacist guidelines for proper prescribing of medications. Mainly this came out of the discussions of hydroxychloroquine and the misguided dispensing and prescribing of that medication by some physicians. PPE conservation guidelines for compounding pharmacies and sterile pharmacies. Allowed out-of-state pharmacists in good standing to be able to temporarily practice in Illinois if needed. Compounding pharmacies were to follow FDA guidance for any temporary compounding of out-of-stock medications for hospitals. And that pharmacists had an expanded scope of practice for ordering, which means prescribing, and administering COVID tests. Yes, you can prescribe under the proclamations at the moment for COVID tests and for COVID vaccines. And Medicaid allowed 90-day supplies and lifted the prohibitions of the SMART Act, thankfully, and also waived for a time the need for signatures. Department of Insurance also waived the need for signatures for a time, and also refill too soon overrides, and try to expand coverage for COVID-related medications. Then finally, pharmacists and technicians have expanded scopes of practice, and pharmacists particularly with ordering and administering COVID vaccines. And we were there in the very early days, helping provide information to you and trying to get out as much guidance as possible. And a lot of it was trying to pull together information that didn't exist. There were not a lot of best guidelines on how to best keep your practices safe. So we worked within ourselves at the various state pharmacy associations, along with APHA, with providing guidance for Illinois recommendations for safe pharmacy practice. We also worked with establishing ethical guidance for best practices in dispensing hydroxychloroquine. We also established patient information leaflets because at that time in the early days, none existed and there was a lot of misinformation, and we wanted to make sure you had the best information to provide to patients. And working together with our partners at ICHP, IRMA, and the long-term care pharmacy providers, we sent in recommendations of over 30 recommendations to Governor Pritzker and how to address the pandemic. And parts or all of about 23 of those recommendations were enacted at some point during the pandemic in those first 6 months. We helped develop communications, help transition our way of learning as we are tonight with virtual learning, and establishment of IPHA town halls, which we were meeting weekly there for a while. And I know a lot of you attended. And now that we've transitioned to our monthly town halls for IPHA. So you can attend our monthly town halls the first Wednesday of every month. We were all over the media, both nationally and locally. And we enacted, we engaged in the media to try to help dispel misinformation, to make sure that patients were ensured that they could safely still get their medications, because in the dark days of this pandemic, pharmacy prevailed. Pharmacy never closed. You kept going to work because we took an oath to serve. And I'm so proud of every one of you. We've had a lot of long days of late over this last year, and a lot of days that really tried us in a lot of different ways. And I really appreciate everything that we've all done to continue to serve our profession, to serve our peers, and to serve our patients. Thank you. HHS expanded the scope of practice for pharmacy, and we've already talked about that with COVID testing. And that was started back in April, that we could order or prescribe and administer COVID tests. In August, it was expanded that we could order and administer and order vaccines for ages 3 to 18, and student pharmacists could help administer down to that age if under the direction of a pharmacist. Then it was expanded that we could also add on COVID vaccines in September. And then October, technicians were allowed to administer across the country if they were properly trained for the ages 3 to 18 and for COVID vaccine. And then Illinois issued their own proclamation, also talking about that for administering influenza and COVID-19 vaccines for Illinois. So this is a huge effort of expansion. The federal government recognized the important role that pharmacists provide in the immunization neighborhood and in the testing neighborhood and point of care. We have been given a huge moment, and we have to grab it with both hands and make sure that we properly administer the new roles and the new powers and authority given to us. And we're going to be working hard through IPHA and through the state associations across the country and our national counterparts in ensuring preservation of these rights after the pandemic begins to ease. APHA has included various resources, and if you have not looked at our vaccine resource guide that's available at ipha.org, I highly recommend that. It's been another great resource that we've developed over the last number of months to help provide you a quick resource of links to all the various departments and pharmacy organizations, and helping make sure that you have the information you need to best address patients' questions and to best set up your practice to be able to provide the COVID-19 vaccine. Quick reminder for the Critical Access Pharmacies Fund, or the CAP Fund. This started in FY19 with a budget of $10 million, but only 4.7 was initially used by pharmacies, and it was renewed in the FY20 budget, and we're hoping it's going to be renewed for the FY21 budget. And that for critical access pharmacies, they must be a brick and mortar pharmacy. They have to be in a county with fewer than 50 residents and own fewer, and the corporation must have less than 10 pharmacies. Now, if you're in a county with 50,000 or more residents, such as in the Chicagoland area, your pharmacy must be in a designated area that's considered to be medically underserved, and that's a federal definition. And a lot of pharmacies that do fit that definition in Cook County specifically. And that there's an attestation at the first couple of weeks of each quarter, and the pharmacies paid almost about a quarter behind because of all the processes that Medicaid has to go through to verify all the data. Pharmacist well-being and resilience. One of the things that came out of the task force in the discussions of some of the Chicago articles, even from a number of years ago, excuse me, is that we have a lot of stresses in our workplace, which we've all known for a long time. But we finally have been able to take the duct tape off those wounds and really examine what is going on and have a very honest discussion in the profession. And I'm really glad that IPHA was able to be part of a national discussion that actually took place in Chicago in July of 2019. And it was called the Enhancing Wellbeing and Resilience Among Pharmacists Workforce. And it was made up of 85 different individuals from across the profession. And we developed a report that focused on 50 various recommendations, looking at the categories of pharmacists and work conditions and patient safety, payment models, because we had to recognize, and this is something I was really driving hard during this workforce, is that labor restrictions, there is a direct relationship between labor restrictions and workforce conditions to the lack of proper reimbursement from pharmacy benefit managers. We also have to look at the relations between pharmacists and employers, pharmacists, students, and student pharmacists' well-being. It's not just pharmacists, it's the whole team. Well-being of education and training, our communications, and just looking in additional research. So this came out as 50 different recommendations, and APHA, ACPE, AACP, NABP, and NASPA submitted the report to the profession and really kind of helped start a national discussion. Now, later in 2020, IPHA, through our House of Delegates, actually put forward our own policy where we endorsed all 50 recommendations of the report. And unfortunately, this discussion kind of got put to the wayside during the pandemic. But I'm glad to say that starting this year, there's going to be some town halls actually here in April that APHA and NASPA are co-sponsoring. And I'm really proud as the current president of NASPA that we're going to have this discussion. It's going to be a hard discussion for the profession to have on these workplace issues, but it's needed. We need to talk about what's going on. We need to be truthful about what's going on. And we need to come up with real solutions that can be enacted in a short-term mindset and be able to look at long-term strategies to help resolve this issue on a nationwide scale. So let's talk about how to meet with your legislators. And this is where we're going to wrap up. So you need to remember, whenever you meet with your legislator, which right now it's mainly virtual, but when you do, make sure to introduce yourself and state why you're meeting with them. Mention any mutual contacts that you have. That always helps with bringing in those contacts in your neighborhood that you have a commonality with. Make sure you emphasize those key points that are personally important to you. Try to keep everything as brief as possible. Make sure to expect questions and be responsive, but do not become argumentative. This is not a debate. Provide them with a brief synopsis of key points, which is what we usually have for our major bills on our action center, our advocacy center. Be enthusiastic and show that you care about the issue. If possible, try to get a commitment of support and let us know what that is. And please follow up with a thank you letter. And that doesn't have to be a handwritten letter, even though that still works. The mail service will still accept those. But just saying a quick email saying, thank you for your time today, and I appreciate your continued support and advocacy for pharmacy. That does a lot with helping get our message across. Because they hear from me all day and every day, and they hear from our lobbyists. but it helps reinforce that when they're hearing it from you in their constituencies, in their districts. Now, let's talk about the things we don't want you to do. We don't want you to be rude or threatening. Don't pretend to have any greater influence than you have. Do not promise anything you can't deliver. Don't be all self-righteous. Please don't be vague. It's hard to understand these healthcare issues, especially with pharmacy. And sometimes it may take multiple meetings for them to fully grasp what's going on. And this is one of the things where education is an all-out effort for all of us throughout our lives with working with our elected officials. Don't forget to thank them for past favors. And please don't bring up any past campaign contributions. It is a violation of the law, and you can't talk about that because it can be considered bribery. So please keep it professional and to the issue. So, and as a reminder, before we get to our questions, is that Illinois Pharmacy Legislative Day is going to be on April 21st. It's actually going to start a week before that on April 14th. And it's going to be a week-long effort of advocacy, showing the Illinois General Assembly that pharmacy's here for the patients, for the long haul. We've had a hard year, but we've stepped up to the plate, and we're ready to serve in better capacities. So it's going to be on April 21st. It's going to be virtual. All of it's going to be virtual. And it's actually a free registration. So there's no excuse for any of you not to be able to participate in some form or fashion throughout the week of advocacy. And we really look forward to all of your help. So let's review our questions again. What was the bill numbers for our 2021 proposed PBM legislation? It's actually A and B. Our Senate version is Senate Bill 2008, and our House version is House Bill 3630. What type of cannabis became legal on January 1st of 2020? Actually, both medical was preserved and made permanent with the pilot program becoming permanent, and recreational cannabis in limited quantities. According to HHS, what's the minimum age that pharmacists may now administer vaccines? It is 3 years old. And with the court case decision in Rutledge versus PCMA, of course, it was that unanimous decision of 8-0, win for patients and a win for pharmacy. So here's my information. Please feel free, email me, call me. I'm here to serve you. And I'm glad to have this partnership, as always, with the Chicago Pharmacists Association. It's vital what we're doing for our patients and our communities and what we're doing on a state and national level and advocating for advancement. We have a lot of work ahead. We always have a lot on our plate, and there's always important issues. But right now, we are at a pivotal point of making sure that pharmacy is preserved for future generations, and I need all your help. So please make sure you're following us on Facebook and Twitter. Please continue, if you haven't had a chance, listen to our podcast, Illinois Farm Talk, where Ben Calcaterra and I co-host and talk on a almost monthly basis on various topics. Our last episode was talking with Dr. Stephen Foster, who is the only pharmacist that sits on the CDC ACIP committee that helps make the recommendations that's been impacting the COVID vaccines. We have a great discussion on the pharmacy development process, vaccine development process, and the role of pharmacists in the immunization neighborhood. But I really want to thank you all. And I'm going to stop the recording here so I can come on live and take any of your questions. So again, thank you.